tuberculosis clinics in these settings, it's striking how few children there are in those clinics. And so you have this dichotomy between a lot of children being started in the hospital very ill. They have about a 20% post-discharge mortality rate among all septic children in the hospital, and then this absence of children in the clinics. So trying to bridge that is an important goal, I think. And then finally, I know I'm out of time, so I just want to point out, this is our website for the CFAR TB HIV working group. And we have a variety of activities coming up. In May, we're planning on a specific symposium on TB in children, neonates, and pregnant women in high HIV prevalent areas. And I think we should figure out a way to link our websites and try to get everyone involved. And I'd be happy to talk with others further about that. So thank you very much. Any questions? Yes?
What's your TB gold standard going to be in this pediatric study? It's very difficult if 20% die. You can't really know that they got better on treatment, and you already know your diagnostic stink. So how are you going to work that out?
No, I think that's a really good point. And I think so for the purpose of evaluating TB bacteremia, culture is our gold standard. In terms of the other cohort where we're really looking at a whole variety of diagnostics, there's two ways that we propose to do that. One is to look at a pooled gold standard that really says if you're positive in any of the above, you're counted as a positive, versus none, which has some limitations for obvious reasons. But it probably is better than any one gold standard, since we know that there is no single gold standard for the diagnosis of TB in children that's going to capture 100% of all infected children. And so I think that's sort of the way that we will approach this. I think it will be interesting to see what we find, because I think it does raise the question of when you get a lot of positives by one assay that aren't positive by others, and you don't have a true gold standard, how do you handle that? So we'll just have to see what we find, but it's a good point.
Can I ask a question?
Yeah, absolutely.
So do you think there's anything that makes children who get TB bacteremia special? Are they biologically different or at risk, or was it just bad luck? And embedded in all of that, what are the biologic hypotheses around those children?
So absolutely. So there's a couple of interesting questions around that. One of the things that we're hoping to do as part of this is to save isolates that we are able to culture. And David Sherman at Seattle Biomedical is very interested in actually looking at full genome analysis. His hypothesis is actually that there may be invasive forms of mycobacterial disease that are different genetically from non-invasive forms. And so we would potentially be able to look at that from the pathogen side. From the host side, I think that there are some known differences. So I think children who are severely malnourished have T-cell defects that are similar to HIV-infected children, HIV-infected children clearly. So those are some knowns. But I think then there are also some really interesting unknowns. I mean, I think many of you are probably familiar with some of the data with deworming and risk of, or of improved responsiveness to BCG following deworming. And a lot of these kids, probably more than 50%, will have chronic exposure to helminths and other infections. And so we are storing and banking samples, and I think that's something that we don't have a really good handle on. And I think separating the difference between host-associated immune or other factors that lead to dissemination versus pathogen-associated factors is tricky, but something that I think as all of us work in this area, if we can start to set up these repositories and banks, hopefully some of the basic science-oriented folks will be able to help us answer those, definitely. Yeah.
Hi, I'm sure you're aware of the new intrathoracic definition, the consensus definition that was proposed last spring. Mm-hmm. I'm just wondering, practically speaking, how feasible is it for you to employ that definition in your cases of suspected intrathoracic TB?
I don't know. I mean, I think from a practical standpoint, we have two very different cohorts here, and they're managed very differently. So among the Nairobi cohort, I think there's a lot more flexibility for both better diagnostics, more complete evaluation, and probably better systematic data collection than in the Western Kenya cohorts. And so I think it's possible, but I think it depends on the cohort. And we can, be happy to talk to you more about it.
Okay. Let's thank Judd.
Thank you.
And then the final speaker of the first session is Max O'Donnell. I want to actually congratulate all speakers for your timeliness. Thank you. So Max O'Donnell is from the Einstein CFAR. He's going to speak on antiretroviral therapy, improving mortality, but not decreasing TB treatment failure in XDR-TB HIV co-infected patients.
Thank you. Great. So again, I'm here on behalf of my collaborators, but also on behalf of the Einstein Montefiore CFAR. And I'm going to speak to you today about ART improving survival, but not TB culture conversion in XDR-TB HIV co-infected patients. I have no significant conflicts of interest to declare. So as we know, TB mortality is worse in drug-resistant TB and also in low CD4 counts. Increased mortality is mitigated in drug-susceptible TB and probably also drug-resistant TB by early antiretroviral therapy. Existing sort of preliminary data suggests that HIV status may not be associated with rates of TB culture conversion clinically, and there's data both from drug-susceptible TB and drug-resistant TB. It's unclear what the effect of antiretroviral therapy has on TB culture conversion in drug-resistant TB. So this is work that I'm carrying on with my collaborators in South Africa, and I'm not going to talk to this group about the co-epidemic of HIV and drug-resistant TB in KwaZulu-Natal, except to say that it's severe. So this is a figure that I put together looking at the hospital that I'm going to describe in this presentation, King George V, and the bluish bars are admissions, annual admissions for MDR-TB, and the other bars are admissions for XDR-TB. So in the years that I'm going to describe, that is patients admitted in 2006, 2007. In 2007, there were 148 admissions for XDR-TB, and that's new, unique admissions. So the objective of this study is to investigate whether HIV status is associated with TB culture conversion for XDR-TB, and a preliminary way to say whether ART is associated with TB culture conversion for these XDR-TB HIV co-infected patients. So this is a study where the cohort was acquired retrospectively, so it was consecutive adult patients who were presenting to this public TB referral hospital in KwaZulu-Natal, South Africa, for the initiation of XDR treatment, and it was between December 2006 and October 2007. And these dates were chosen, December 2006 was chosen because capreomycin became available through the public hospital system at that point. And there was just a different regimen available to treat the patients. These patients all had XDR-TB by drug susceptibility testing. They agreed to initiate treatment, and we excluded retreatment and readmission patients who were readmitted or retreated for XDR-TB. We collected demographics and clinical data from chart review, and we got culture data and treatment outcome data prospectively over time from the provincial lab and hospital databases. Ethical approval was obtained through Boston University, where I was at the time, and University of KwaZulu-Natal. So this is a demographics sheet of the cohort. So there are 114 XDR patients enrolled in this group. As we've published previously, in KwaZulu-Natal, XDR patients are more likely to be female rather than male, and we stratified this group by gender. So the women were younger than the men, so the median age was 31 as opposed to the men's median age 39. They were more likely to be HIV infected, so 80% of women in this cohort were HIV co-infected, whereas 61% of the men were. Unlike in other data presented from sub-Saharan Africa, these women actually had higher CD4 counts on average than the men, but this was not statistically significant. The median CD4 count for the entire group was 197. So 61% of these patients were on ART. This ART, except for a few cases, 3 cases, was started in hospital. Was started prior to hospitalization, prior to initiation of treatment for XDR-TB. Patients had numerous adverse events and also severe adverse events. 80% of them were previously TB treated, and many of those, 60%, were previously diagnosed with MDR. So I'm not going to talk actually a lot about the treatment or the treatment outcomes in these 114 patients, but suffice it to say is that the treatment is outcomes are very poor. So 22% of them had a successful treatment outcome, either cure or treatment completion, and this is at 24 months after the initiation of treatment. And whereas 17% of them defaulted, 19% failed treatment, and fully 42% or 48 of these patients died during treatment. So when we look at this is a Kaplan-Meier curve representing survival from the time of treatment initiation with XDR-TB treatment. And what we see is that HIV-infected and uninfected XDR patients have similar survival. And this is broadly consistent with work that we've published earlier, as well as work that Kirtan Data and his group in Cape Town have published in The Lancet. On the other hand, when we stratify by antiretroviral therapy among the HIV co-infected patients, so the 82 patients who have HIV, we find that in fact there is an early difference in mortality that is maintained out through the 24 months. So in the dashed line, you see the patients on antiretroviral therapy, and their probability of death is about 35% or so at 2 years, whereas those HIV-infected patients not on antiretroviral therapy have about a 60% mortality. On the other hand, when we look at the probability of culture conversion for these HIV-infected and uninfected patients, we also see that HIV is not a risk factor for culture conversion. The dashed line is the HIV positive, and the solid line is the HIV negative. And well, is that important? Yeah, actually it is. So this figure looks at all patients, HIV infected and not, and looks at culture conversion. The patients who converted early, the patients who converted, that is within 2 months, that's in the dashed line, the solid line is less than 2 months. Patients who converted after 2 months, the median time of culture conversion was 4 months. And the patients who did not convert. And what you see is that the mortality rate for non-conversion in these patients is very high. So then we looked at, among the HIV-infected patients, looked at risk factors for culture conversion. And this is at 2 months, but we did it at various time points. I'm just going to show you at 2 months and 24 months. This is a multivariate, univariate, and then a multivariate model using Cox proportional hazards, and found that there, in fact, were no statistically significant factors associated with culture conversion, and in particular, antiretroviral therapy was not associated either with early culture conversion or at 24 months with eventual culture conversion. So I'm going to wrap this up really early, and I'm sure people will be happy to get a snack, but I'll sort of say that patients with XDR-TB HIV have poor outcomes and high mortality at 24 months. Treatment with antiretroviral therapy is associated with improved survival in XDR-TB HIV, and I'm actually going to have a poster tomorrow where I'm going to go into a lot more of the data on survival and on conversion, predicting survival and outcome. But HIV co-infection does not significantly reduce rates of XDR-TB culture conversion in this group. And antiretroviral therapy for XDR-TB co-infected patients improves early mortality, but it doesn't improve TB treatment outcomes for those who survive. This is obviously controversial and preliminary data. We're currently are in almost year 2 of a prospective study of XDR-TB HIV co-infection looking at this specific question. So I'd like to thank my collaborators at King George, Iqbal Master, Garth Osborne, Harris Goldstein from the Einstein CFAR for getting me here, Nesri Padiachi from the Center for AIDS Program of Research in South Africa, and Lisa Warner from the same, and Bob Horsberg, my fellowship mentor and still collaborator. Thank you.
So you said that lack of conversion is associated with death, but don't you think it's really just the other way around, that people who died don't live long enough to convert?
Right.
Instead of not converting, killing them?
So certainly death is a competing outcome for culture conversion, you could say. But you know, I mean, we tried to handle that statistically, you know, by censoring patients, you know, at different time points, you know, at time of death or default, and trying to handle it that way, and looking also at early culture conversion as a place where antiretroviral therapy might be effective as well. But yeah.
So maybe a naive question. So does this mean that there's no role for immunological control of XDR-TB and that it's all pharmacological?
Well, you know, so we've tried to explore this in some detail. You know, some things that we've found is that these medicines that we're treating these patients with are really ineffective, and they're really ineffective because most of these patients have, you know, very common RRS mutations that are making them, you know, insensitive to some of the capreomycin that they're getting. So that's part of it. You know, another part is that, you know, many of these patients, nearly all of these patients, were not getting, as part of their treatment regimen, we're not getting second-line fluoroquinolones, which is potentially important. When we look at moxifloxacin MICs in these patients, roughly a third of them will have MICs of moxifloxacin less than 1, even though they're formerly resistant to ofloxacin. So I think it is partly that these are very treatment-experienced patients, but it does sort of raise the question, right, that we're treating, you know, getting everybody on ART, and in a way, you know, what we're doing is prolonging survival, but not improving, in this group anyway, rates of culture conversion. So we're spreading densely resistant disease.
In many other parts of sub-Saharan Africa, there has been, or being male actually is a risk factor for TB. Most males have TB and MDR-TB.
All around the world, right?
Yes. The fact that that in these patients admitted to the hospital, there are much less men than females suggests that there may be a bias, a selection bias, and that the HIV positive MDR or XDR-TB patients, actually, which are males, are dying in the community. So,
yeah.
I don't know.
No, you're right. You know, there's at least 5 or 6 different possible sort of biases that could be explaining that result, and I wouldn't sort of put it forward as anything but an epidemiologic result. You know, it could have to do with a number of different factors that we've thought about, but you know, so and including exposure in the community. So if you look at work done by Neil Gandhi and Sarita Shah, you see that